My name is Jen, and today we're going to be going over 3 different evaluation of movement patterns. Movement pattern analysis is always more reliable. When observing movement patterns, we don't want to focus not only on the strength of the movement, but more importantly, the sequencing and activation of all the synergists involved in the movement. The initiation of the movement is more important than the final phase or completion of the movement. The first movement pattern test that we're going to look over is hip extension. This is going to assess recruitment patterns for the gluteus maximus, the hamstrings, and the spinal extensors. What we're going to do is we're going to get the patient to lie prone with the arms at the side and feet hanging over the edge to allow for a neutral position. The head should be in as neutral position as possible. What we're going to do is ask the patient to lift the legs slowly towards the ceiling. Okay, if we want to position our hands, which ideally we don't want to, but if we're going to, we want to put it on the hamstrings, the glute max, and the erector spinae. Normal movement patterns is going to be the hamstrings, the gluteus maximus, the contralateral erectoral spinae, to the ipsilateral erector spinae. Ideally, we'd love the glute max and the contralateral back extensors to initiate. Okay, the hamstrings may also fire in conjunction with the glute max. Some faulty movement patterns that we might see is an overactivation of the hamstrings and erector spinae, okay, and an absent contraction of the gluteus maximus. As well, we may see an inability to maintain knee extension, and this should be noted as this may mean that there is hamstring dominance over the gluteus maximus. If the lats are contracted during hip extension, this shows poor spinal stabilization. The second movement pattern test we're going to look at is the hip adduction movement pattern test. This test will assess abductor strength as a brace and stabilizer in the frontal plane. First, we are going to get the patient to lie on their side with the bottom leg in the flexed position. The top leg should be placed in neutral position and in line with the trunk. The prime movers for this movement are the gluteus medius, the gluteus minimus, the TFL, and the QL and abdominal muscles used to stabilize the pelvis during this limb movement. We want to instruct the patient to lift the leg towards the ceiling. The normal movement pattern test of hip abduction is abduction to 20 degrees without any hip flexion or internal or external rotation. Some faulty movements that we might see is that the TFL will overreact. Okay, this is evident in both hip abduction and hip flexion. Second, the QL or the ipsilateral side will fire, resulting in a lateral hip hike or tilt. Here the QL becomes the prime mover, okay, and instead it should be the stabilizer. If there is any rotation of the hip, the rectus femoris becomes synergistically dominant, and that's not what we want. I want you to think about just raising that to the ceiling, okay? And go. Okay. And shift this pelvis just a little bit forward, okay? And one more time. And last time. Okay. Whoa! Can bring it back down. Okay. And go there. Okay. And bring it back down. That surprised you. Okay, so now I want you to bring it just back, straight, a little bit back, and do it one more time. Okay, bring it back down. The last test that we're going to look at is the cervical flexion movement pattern test. This test is for people with neck pain or neck pain after a whiplash injury. It's going to test the impairments in the strength and endurance needed by the deep neck flexors for segmental control and support. It will as well assess the deep neck flexors, which create head and cervical flexion, versus the synergistics, the scalenes, and the SCM. This test may be great for patients who experience recurrent headaches. The preferred movement that we're looking for is that the head and cervical spinal flexion occurs before head is lifted from the floor. The test is positive when the chin or jaw juts forward at the initiation of the movement. We don't want to see that chin lead the movement. A jutting chin or jaw suggests a dominance in the SCM and scalenes over the weaker cervical flexors. A forward head posture indicates weak or inhibited deep cervical flexors. Observation of bulkiness at the middle of the SCM when the patient is at rest may also suggest weakness of these flexors. If the pattern is unclear, what we can do is we can place 1 to 2 fingers against the patient's forehead to apply a slight resistance to the movement. This will allow us to detect any anterior translation of the cervical segments, which would confirm inadequate stabilization by deep cervical flexors. The main thing that we're looking for here is that the chin is jutting out, because this would be an indication of a positive test.